because of blurry vision in her left eye. Okay. She had breast cancer 3 years earlier that was treated with local excision and an axillary-node dissection, radiation, and hormonal therapy. Now she's looking up, which you can tell by the wrinkles in her forehead, and her right eye is moving up appropriately, but the left eye evidently can't. And outward, the pupil seems no different in size than this one. Now if we go over these items that are offered, this eye, the left eye, actually looks proptotic. Now, Graves' ophthalmopathy can occur unilaterally, but that's not very common. And since there's absolutely no evidence of anything going on in the normal eye, I think that that possibility is unlikely. Orbital cellulitis and inflammatory disease ought to be accompanied by redness and swelling and problems of this nature, and those are not present. So the differential diagnosis is orbital metastases and partial cranial nerve palsy. And we'll have to pick orbital metastases. First of all, it's the worst diagnosis, although I wouldn't want a third nerve palsy either. And there are several reasons why that's the correct answer. So that's the correct answer, and next week we'll find some details on this and get to look at this metastasis probably with magnetic resonance imaging. Now, with the third nerve palsy, the individuals look down and out. That's correct. If the nerve is compromised by getting squeezed or something of that nature, we would expect the pupil to be dilated compared to this eye. The fibers to the dilator pupillae run within the third nerve, although actually anatomically they're not really a part of the third nerve itself. But with the third nerve palsy, we would expect the eyeball to collapse rather than to be proptotic. That makes the diagnosis of metastasis far more likely than third nerve palsy. Now, the first topic of the New England Journal concerns hypoxia-inducible factor. There are several of these. And these are produced continually constitutively. They enter the nucleus of many cells and bind to cyclic AMP binding protein and turn on a host of genes, including the gene for erythropoiesis. Now, HIF is regulated by an oxygen sensor that involves prolyne hydroxylases that are able to hydroxylate HIF-1 alpha. And when HIF-1 alpha is hydroxylated, it binds with the von Hippel-Lindau tumor suppressor protein, and this entire complex is degraded in the proteasome. So that's the oxygen sensor. With hypoxia, the prolyne hydroxylases are not able to hydroxylate HIF, and then HIF moves into the nucleus to perform its duties there. Now, erythropoietin is a glycoprotein hormone that's involved in the formation of erythrocytes, and it's produced by a particular layer of inside the kidney, peritubular fibroblasts that are situated so that they are particularly sensitive to hypoxia. And the oxygen sensor then regulates HIF that's responsible for the elaboration of erythropoietin. Erythropoietin is a cytokine, so that it binds to a cytokine receptor and at various places, including in the bone marrow, to result in more erythropoiesis. Now, I could speak for an hour on iron metabolism in and of itself, but we'll look at some elements in detail. Now, the prolyne hydroxylase is an enzyme. There are numerous prolyne hydroxylases, and they're important in collagen and elastin regulation and various things of this nature, but they have a unique function in regulating HIF, so that when HIF-1 alpha is hydroxylated by prolyne hydroxylases, and there are also 3 of these, then this hydroxylated HIF binds to the von Hippel-Lindau protein and is ubiquitinated and is degraded. However, if that's not the case, if the proline hydroxylases don't have oxygen available to do this hydroxylation step, then HIF-1 alpha binds to cyclic AMP response element binding protein, enters the nucleus, and turns on all the HIF responsive genes. So that's basically how that works. Now, Roxadustat is a HIF stabilizer. Basically what it does is it inhibits proline hydroxylases so that HIF can't be hydroxylated, so that the HIF that's there then stimulates erythropoietin release, resulting in the formation of more erythrocytes. Now, one of the players in this schema is hepcidin. There are numerous iron regulatory proteins, but hepcidin plays a central role in the anemia that accompanies renal failure and inflammation. So hepcidin is produced by the liver and it regulates iron absorption. We have about 5 grams of iron in the body, about 60% is inside erythrocytes, and the other 40% are in other stores. We absorb about 1 milligram of iron per day, and the excretory capacities for getting rid of iron are limited. Now, women lose iron in the menstrual cycle about 30 milligrams, which is similar to what they ingest every day. Men don't have that option, so iron resorption is regulated by hepcidin. And hepcidin has numerous important functions. In addition to regulating iron absorption, it also responds to inflammatory factors in terms of its synthesis, and chronic renal disease is associated with inflammation. So hepcidin levels in chronic renal disease are high. So this is basically hepcidin that is blocked by these various factors, and which blocks these mechanisms up here. So it's a complex protein, but it plays a role in the story that I'm about to show you. So Roxadustat is an oral inhibitor of hypoxia-inducible factor prolyl hydroxylases. And with inhibition of these prolyl hydroxylases, erythropoiesis should be stimulated and iron metabolism should be regulated accordingly, and hepcidin should be downregulated. Now, in this first study that was performed in China, we see 150 patients with chronic renal disease. And if we look at them, a little difficult to discern here, but I did it for you, their mean glomerular filtration rate is 15 milliliters per minute. And they're men and women, and obviously they have a hemoglobin of about 8, which would have 8.7 or 8.9 that we would expect in patients with renal disease to this degree. They also have signs of inflammation. C-reactive protein is 89, and no significant difference here, but C-reactive protein is elevated in both groups, and the randomization here was 2 to 1. So 2 got Roxadustat and 1 got placebo, and the primary endpoint is the mean change in hemoglobin over a limited period of time, only 8 weeks. And what we see here is the patients that got Roxadustat had an increase in their hemoglobin to almost 11, whereas the placebo patients didn't move. So that looks pretty good. Now, what we also see is that hepcidin was suppressed by Roxadustat, and the decrease in hepcidin is substantial compared to placebo that in essence had no effect on hepcidin. So if we look at these variables here, transferrin goes up, total iron binding capacity goes up, transferrin saturation goes down, and ferritin levels also decrease because now the iron is being utilized for a useful purpose. Now, if we look at these absolute hemoglobin levels, they look pretty good. Now, after 8 weeks, what was done is the placebo patients also got the drug. And what we see here is that the hemoglobins in the placebo patients then moved to the same level as the patients that got the proline hydroxylase inhibitor until the termination of the study when the drug was stopped, and then these values decrease. Now, I guess the side effects are hyperkalemia and metabolic acidosis. Now, hyperkalemia showed up in 16% of the Roxadustat patients and in 8% of the placebo patients. And metabolic acidosis was also more common, although the investigators don't tell us bicarbonate levels, and I don't know what type of metabolic acidosis this was, and I'm not aware of its severity. But nobody died of either one of these complications. And if we look at the serum potassium levels throughout the entire treatment period, they really don't look significantly different in the two groups. But the percentage of patients that once had a potassium of greater than 5.5, which wouldn't bother me, was higher in the Roxadustat group than compared to the placebo group. What's also interesting is that total cholesterol dropped in the Roxadustat group substantially, LDL, and that was based on a reduction in LDL cholesterol. And triglyceride levels also decreased, so the lipid values got better, and the authors speculate on what Roxadustat might do to HMG-CoA reductase that would explain these changes. So in summary, cholesterol levels decreased by 23%. Roxadustat looked pretty impressive in terms of raising hemoglobin levels in these patients with chronic renal insufficiency. The notable complications might be hyperkalemia, although that doesn't look very impressive if we can believe the author's data, and some degree of metabolic acidosis, but we weren't given any further information on that. Now, in the next study, also from China, the same drug was tried in hemodialysis patients. Now, these hemodialysis patients had all been getting erythropoietin. So in half the dialysis patients, this is also a randomization of 2-to-1, as I see. So in the Roxadustat patients, the erythropoietin was stopped and Roxadustat was separated, and in the other group, erythropoietin administration was continued according to current guidelines. And the idea here is to show that Roxadustat is no worse than erythropoietin. But what we see here is there's an abrupt increase in hemoglobin levels in the Roxadustat patients, and the people that were getting erythropoietin according to guidelines had their dose of erythropoietin increased, so that at the end of the study the levels are no different. But what we also see here is hepcidin levels decreased in the group getting Roxadustat, and there was no change in hepcidin in the erythropoietin group. And if we look at the changes in transferrin, total iron binding capacity, transferrin saturation, and ferritin, there are some changes here that are reminiscent of the changes seen in the first study, but since the control group got erythropoietin, an active component, the differences between the two treatments are not that apparent. But what we see here is that if we look at the patients that have a substantial elevation in C-reactive protein, those are the ones that with the most inflammation, they respond to Roxadustat anyway, as well as the patients that don't have this elevation. Whereas in the erythropoietin group, the inflamed individuals seem to be relatively resistant to erythropoietin. And in the course of the study, erythropoietin had to be increased in the patients, whereas Roxadustat could be decreased during the maintenance of hemoglobin levels to guideline degrees. And again, hyperkalemia shows up here. Metabolic acidosis does not show up here, but again, the degree of hyperkalemia seems to be relatively limited because the percentage of patients with elevated potassium levels doesn't look that impressive, and what the authors had to do about it is not entirely clear. At least no one died of hyperkalemia. Interestingly, physicians are much more afraid of hyperkalemia than they are of hypokalemia, although in my view, hypokalemia is more dangerous. Now, the mechanism of the hyperkalemia the authors admit is not entirely clear, so that will have to be explored in further studies. I think what these studies also show is the tremendous proclivity that the Chinese have with their population of 1.3 billion of conducting randomized controlled trials of these issues. And both of these trials appeared exceptionally well done. Now, the next topic involves interleukin-5. And interleukin-5 is also a cytokine, and is the Eosinophils Cytokine, and it binds on the EL5 receptors, and the EL5 receptors then signal the production of eosinophils. And eosinophils play a role in a whole host of diseases. For our purposes of this next study, we're interested in patients that have chronic lung disease or bronchospasm, asthmatic chronic lung disease. And the drug that binds to the EL5 receptor, benralizumab, and the effects that we would expect it to have are shown in this little insert. So in this study, here patients with COPD, and these patients have chronic lung disease, and there were 2 studies that were performed here. Several doses of benralizumab were compared to placebo, and the idea here is to suppress eosinophils in the hope that therefore exacerbations of COPD would be less. Hope springs eternal. Now if we look at these patients, all of them are smokers, and every group, and although some of them claim that they've stopped smoking, if we look at their general cigarette consumption, they all have over 44 pack years of smoking. So you would think that people that have chronic obstructive lung disease with 44 pack years of smoking probably are not going to have very much of a reversible component. Indeed, that appeared to be the case, because if we look at this complicated table here, there were no significant difference in exacerbations or severe exacerbations or differences in lung function or quality of life among these groups at all the doses tested. So here are the exacerbations, and in some it looks like it might have got a little less with the highest dose of benralizumab, but the significance of these changes was limited. And the side effects were, most of the side effects that were tallied here were related to COPD or respiratory conditions. So if we observe that the COPD didn't get any better, then the side effects related to COPD would remain elevated in all the groups. So if we look at the data in detail, the drug is great at decreasing eosinophil counts. And here are several different doses, and boom, eosinophil counts go way down in both studies. But if we look at, even if the patients that have the higher eosinophil counts, there's no difference in exacerbations with the treatment. So I think that this study was probably hopeless. These people have chronic lung disease from over 40 pack years of smoking, and it's not going to get much better if we lower their eosinophil counts. The next topic is icosanoids. And unless you are an investigator of icosanoids and go over this material every day, this stuff is difficult to remember. But you'll recall that arachidonic acid is metabolized through various different pathways. And one of them involves cyclooxygenases, and COX-1 and COX-2. And they're inhibited by COX-1 and COX-2 inhibitors. And they make good prostaglandins, PGI2 and PGE2, and thromboxane, which is not so good. Then there are lipoxygenase products, and these are the heats and PEATs and things of this nature, and most of those are fairly unfriendly also. Then there are the products of CYP450 microoxygenases, and they make stuff that mostly is favorable because they make icosapentaenoic acid and other things that have a salubrious effect on vascular contraction and things of this nature. And there's a lot of interest in developing drugs to inhibit the catabolism of these products. Soluble epoxide hydrolase is the enzyme that's addressed here. And then there are isoprostanes. I think they're fairly unfriendly too. So that's icosanoids in a nutshell. Now, if we eat a lot of fish oil, we ought to get more of the good stuff and less of the bad stuff. And there's a hope springs eternal. There's much hope that fish oil or some product in fish oil might be salubrious for patients with chronic vascular disease. Now, omega-3 fatty acids, and this is counted from, there are two ends of a fatty acid. There's a carboxy end and an amino end. Alpha and omega, and these double bonds here are important. And so a double bond at the 6th position is shown here, and a double bond at the 3 position is shown here. And these fatty acids that have these are called omega-3 fatty acids, or also N3 fatty acids, because they're on the amino terminus. So if we take fish oil, we get icosapentaenoic acid, which is supposed to be good, and all these other things which are probably also supposed to be good, but fish oil is a mixture of all of these things. Now there's a rumor that feeding pregnant women fish oil might diminish the possibility of premature birth. And so that was tested in this Australian study. A lot of pregnant ladies here, 2,700 in each group. They were randomized to fish oil or vegetable oil. Now the fish oil contains N3 long-chain polyunsaturated fatty acids, and they're supposed to be good. So here we look at the patients, and they were randomized in both groups in a similar fashion, and so the randomization seems to be okay. And the endpoint is whether or not preterm delivery occurred, which was defined as delivery before 34th week of gestation. Now, unfortunately, these data are all tabulary, but you'll notice that there's no difference in these two groups with one exception, and that's shown here. The fish oil ladies were more prone to have very large for gestational age infants, births that were not related to diabetes. That may not be so good, but it may have just happened by chance. And the serious adverse effects, polyunsaturated oils are supposed to be good irrespective of where the double bonds are, and that looked okay. So basically, fish oil or N3 long-chain polyunsaturated fatty acids did not have a lower risk of early preterm delivery, and they were associated with very large for gestational age infants, and the authors discussed that issue, how it might have occurred, but basically no one knows. Now, the review in the New England Journal concerns hypertension in patients with asthma. You'll recall that about 20% of the adults on the planet are hypertensive, and elevated systolic blood pressure is the primary determinant of death. As a matter of fact, it's twice as important as even as smoking or blood sugar or blood lipids, etc. Now, it turns out that asthma is perhaps not quite as common as hypertension, but patients that have asthma commonly also have hypertension. And asthma can be divided into type 2 high endotype or type 2 low endotype. I think we used to call this intrinsic and extrinsic asthma, but investigators have made new names for these topics so that I get confused. At any rate, the type 2 high endotypes have the eosinophils, so they would get better with an IL-5 pathway inhibitor, and the type 2 low endotypes have mostly neutrophils. So this is discussed in tedious detail, and there are some similarities in asthma in terms of vascular smooth muscle cell proliferation, be that in airways or in small blood vessels, similarities between hypertension and asthma. And of course, here's the wondrous microbiome, which is also a topic of investigation at our institution. And the inflammatory responses, be they type 1 or involve IL-17, also play a role in both diseases. And so there's a lot of interplay between dendritic cells and the type of macrophages that do signaling here, and Tregs and inflammatory T cells and a whole bunch of things that you can, so that there are a lot of junctions between the inflammation of asthma and the inflammation that's involved in hypertension. So obesity and metabolic dysfunction are important in everything, in smooth muscle remodeling and vascular biology, and of course dietary salt, I guess, and then management. Now, I would think that beta blockers are a bad idea in people with bronchospasm, and our British colleagues have shown beyond the shadow of a doubt that beta blockers don't protect much from stroke, and that's one of the things that we'd like to avoid. And people that get ACE inhibitors, 10 to 15% of them start to cough. Oh, they may not tell you that. And if they have asthma, this risk is probably increased. So we may want to look at our therapy accordingly. Now, if you're going to give a patient a thiazide-type diuretic, please pick chlorthalidone, which is cheap and effective. And if you give an ACE inhibitor, please be aware that cough might be a problem, not to mention neurotic edema and other items. Now, the calcium channel blocker that's the least expensive in my view and is the longest acting is amlodipine. And you can make your own mind up which angiotensin receptor blocker would be better, but I think those would be advisable, and probably beta blockers should not be given unless the patients have heart failure or some other specific reason. So the conclusion is pharmacotherapy should be adjusted per each individual. We now call that personalized medicine. Hippocrates was aware of that. And changes in lifestyle, people shouldn't smoke and they shouldn't be overweight and they ought to eat less salt, according to the authors. Incidentally, these are Kirschmann's spirals, which are casts that consist mostly of eosinophils, and looking at sputum of asthmatics is still helpful. This patient should have gotten an IL-5 inhibitor, and these Kirschmann spirals are named after Heinrich Kirschmann from 1846 to 1910. This is a tragic case. This person shows up in a dermatology clinic with this awful squamous cell carcinoma of his palm. Turns out 40 years earlier, he had had his palms irradiated because he had sweaty palms. That was stupid, and it results in a risk from squamous cell carcinoma, and this patient died of that condition. Here's the patient from last week with chickenpox. And he indeed has chickenpox, but he also has chickenpox pneumonia. This was an immunosuppressed patient with aplastic anemia receiving cyclosporin, and he died of chickenpox pneumonia. Good thing we have a vaccine for this stuff. Now, the case in the New England Journal, I have to give you some tips on it because this is rather complicated. You'll recall that cells have a skeleton. They do, and the skeleton, it varies from cell to cell, but it commonly is an actin filament skeleton that gives the cells their characteristic shape. Prime examples are erythrocytes that have to have a very specific shape so that they conduct their function. Now, the actin cytoskeleton is bound to cell membranes by anchoring proteins or scaffold proteins, and one of these scaffold proteins is filament A. And filament A can also affect calcium inflow and in various channels, and that's all known. But it's well worthwhile to know that problems with filament A can cause disease that we generally don't think about. And the patient is a 22-year-old woman that comes in with chest pain and dyspnea. Now, shortly after she was born, she was noted to be short of breath back then, and she was tested for alpha-1 antitrypsin deficiency, and she didn't have cystic fibrosis. Alpha-1 antitrypsin deficiency usually doesn't cause symptoms until later in adulthood, like age 40. So that was an unlikely diagnosis in the first place. At any rate, she has some spotty areas of emphysema and actually has a lung biopsy, and it shows this disruption of alveolar septa. And these histological changes shown here. This is bronchiolitis. And 20 years ago, nobody knew exactly what this young lady has. So now she comes in and she's short of breath and has some heart murmurs and various things. And if we look at this CT here, it looks like she has a big pulmonary artery segment, and her pulmonary artery is indeed larger than her aorta. And that could also be detected by auscultation. So she has pulmonary hypertension and also has some valve problems. Now, they measured pulmonary functions in this patient, and her FEV1 is limited, and her total lung capacity is reduced. So all of these things were noted. It was also observed that she has lax joints, particularly joints involving her fingers, so she can bend her fingers over backwards, and her elbow joints are also lax. Somebody was interested in this, so she was tested for Marfan syndrome, which is a fibrillin mutation, but she didn't have that. And there's also an echo in the New England Journal that you may want to look at. We can't appreciate that here. I don't know how to make these run yet on these presentations. But at any rate, she has a markedly dilated right ventricle, and she has some aortic insufficiency and some other things, but because of her pulmonary hypertension, and she has some problems on the left side as well. She also had a pneumothorax when she was 6 years of age, which I think is also notable. So the discussant here considers, does she have emphysematous obstructive lung disease? Basically, yes, but what's the etiology? And is this an example of bronchiolitis obliterans? Well, she hasn't been poisoned with Siedel-Filler's disease. is this a primary lung disease, and what childhood interstitial lung diseases would be involved here, or is this an immunodeficiency syndrome, or is this an autoimmune disease? So all these possibilities are discussed, and then the laxity of the joints, the heart disease, the lung disease are considered in a series of connective tissue disorders. Ehlers-Danlos syndrome, Loeys-Dietz syndrome, TGF-beta receptor mutations, Marfan syndrome, these are all discussed, but the discussant decides that this patient has a mutation in filament A, and genetic testing indeed showed that she had a mutation in filament A, and this was apparently a de novo mutation because her mother didn't have the mutation. So she's getting sildenafil and bosentan for pulmonary hypertension. I think riociguat would be better. And she has an FLNA mutation, and the prognosis isn't very good, so probably some sort of transplantation is being considered. Now, in the Lancet, the first study is also on patients with mild to moderate asthma. And there are some drugs given here. Budesonide is a synthetic glucocorticoid. Formoterol is a beta-2 sympathomimetic compound, and terbutaline is also a sympathomimetic compound that's usually short-acting. So the patients here were randomized to receive LABA or SABA. SABA is basically the SABA group got a budesonide as background and sucked on a terbutaline inhaler when they needed it. And the other group got budesonide and formoterol during the entire course of the study. Now, you can imagine which treatment was better, and it looks like LABAs beat SABAs by a substantial degree. So it looks like it's better to give these asthmatic patients something that has a background, long-acting background in any event, rather than confronting them with some short-acting compound that they have to have in their pocket when they get short of breath, and various subgroups on the basis of pulmonary function and where they're from, and all of these things seem to make no difference. And the daily drug doses were also better in the maintenance group on the whole, of course, than in the short-acting group. So budesonide formoterol reliever therapy is superior to maintenance budesonide plus terbutaline as needed. Now the next topic in the Lancet is Plasmodium Vivax. Now you'll remember that malaria is transmitted by the Anopheles mosquito. Now Vivax malaria is not deadly because the disease has accommodated us fairly well to the host. But Vivax malaria has one specific problem. That is, it has a hepatic stage. And the organisms invade the liver first before they're spread into the general circulation. And inside the liver, they make these hypnozoites, which years later, or months later, weeks later, years later, can rupture and reactivate the disease. So the idea is to kill the hypnozoites in patients with Vivax malaria. Now, falciparum malaria, which is more deadly, doesn't have a hepatic stage, at least not yet. So what was done here, we can get rid of the hypnozoites if we give the patients primaquine. And it was a wondrous time 50 years ago when chloroquine and primaquine cleared nearly all this stuff. But things aren't that easy anymore. And primaquine, first of all, causes hemolytic anemia in people with G6PD deficiency, which is common in subequatorial Africa. And the question here is, can we obliterate the hypnozoites with a 7-day regimen of primaquine compared to a 14-day regimen of primaquine? Now, you might think that this hypothesis is fairly trivial, but it's not, because to get patients to take something for 7 days is easier than getting to take it for 14 days. So these youngsters were randomized to treatment, and people with G6PD deficiency were not included in the study. And basically what we see here is the 7-day and the 14-day regimens were equivalent, and the placebo group had relapse, as we know from the disease. So it looks like 7 days is as good as 14 days, which is important when we're treating young people with this problem. Now, the next review I think is important, particularly for psychiatrists. And these sorts of reviews show up in the Lancet periodically. This is a review of 32 oral antipsychotic drugs compared to placebo in a network meta-analysis to determine what is actually better. And here are the drugs. I circled all the ones in red that I was familiar with when I was still allowed to practice medicine. And all these other compounds, most of them I've never heard of before. Now the placebo ball is the biggest because these were placebo-controlled trials, and every one of these trials had a placebo group, and that's why placebo is the biggest. The experience with haloperidol is fairly reasonable. Risperidone has been studied to a degree, and the other drugs to a lesser degree. And if we look at overall change in symptoms, well, I was kind of happy that thioridazine is something I've heard of, is at least up there, and you can look at the details here yourself. Positive effect on symptoms, negative effect on symptoms, depressive symptoms, social function, all people that discontinued the drugs, and so all the drugs are listed here, and you can look up the abbreviation of your favorite. Weight gain favors placebo practically for all of them, so that you can expect your patients to gain weight. Parkinsonian symptoms, tardive dyskinesia, and this sort of thing. Looks like the old drugs have more of these problems. Here's haloperidol than the new drugs, but basically the efficacy of the old drugs compared to the new drugs is not that much different. Prolactin elevations, akathisia, jerking movements, QT prolongation is also shown here. I'm looking for haloperidol because that's the one that people are always usually worried. There it is. So it's actually not so bad. Sedation. All of this is shown here. Cholinergic side effects. Anticholinergic side effects. And they're thioridazine, pretty anticholinergic. So those things are listed here. So this is important for physicians that use these compounds so that they can use informed decision making. Now the reviews in the Lancet concern drug-resistant TB, terribly important problem. Major efforts being made to try to eliminate tuberculosis worldwide. Drug resistance TB is mostly Soviet Union, Ukraine, and Mongolia, and or I guess this is Turkmenistan, or something. I don't really know. But China has a problem, but not quite as bad as these areas. Then the blue areas are fairly limited. Most of these problems occur in people that are immunosuppressed, HIV patients, drug users, etc. And then large expanses where there are no data. Now, fortunately, we have some molecular genetic mechanisms of making a quick diagnosis so that we don't have to wait for 6 weeks for some organisms to grow out. And then the compounds and their resistance are outlined here. And if you're into this, you can look at this in some detail. And also the regimens. I think these patients are routinely treated with a 4 to 6 drug regimen to try to keep this disease in check. Streptomycin, still there, good thing too. So there's a step decision-making tree that's given here, and details on how these patients have to be taken care of. Everybody ought to get holistic care, I suppose, and that's discussed here. Drug susceptibility testing, fortunately with molecular techniques now, that's easier than it was. And the next review is on childhood tuberculosis. Different problem, different areas of the world. Look at this, childhood tuberculosis, subequatorial Africa, India, and Mongolia, and somewhat less so in China. Also big time problems, and how to deal with it, because children are a little different. These children don't necessarily have multiple drug resistance tuberculosis, but childhood tuberculosis, how to get these youngsters diagnosed and how to get them to take their drugs, have to be treated for a long time, and what to do with very young children, and what to do with their families, and all of these problems are discussed here in substantial detail. Now, before we quit, I thought you might be interested in this. Being a nephrologist in Germany, I'm commonly asked, how much should I be drinking? And I usually answer, well, were we talking about water or wine? So here the issue, we're talking about water. And I really can't answer that. I usually tell the people to let the thirst mechanism figure it out. But in this study, mice were randomized to a high water intake or a low water intake. And they were randomized to the point that some bad things happened to the mice that developed chronic dehydration. And the mice also get hypernatremia, as you would expect. Now, how do you do this? You can't do it on the basis of water bottles. So these mice are given different amounts of jello, which contains a large amount of water. And so they eat all the jello. And so the water-restricted mice just got less jello than the ad-lib water mice. And if we look at that, you might imagine if you're water-restricted, your urine osmolality goes up, and the water-restricted mice had an osmolality of 2,500 compared to the mice that got adequate amounts of water. Now, over the months, they gain less weight, and then after a certain 10 months of age, they begin to lose weight, and they're puny. They just do poorly. And what we see is that the water-restricted mice die at a much younger age than the mice getting in normal amounts of water. So the difference in longevity is about 6 months here, which is notable. Could that be a reduction in lifespan of maybe 30%? And if we look at these poor guys, the water-restricted mice are scruffy and they're just not doing very well. And their energy expenditure is nevertheless high. And their oxygen consumption compared to CO2 expectoration is also different. But that it changes over time, so that after 13 months, they're not doing very well in terms of oxygen consumption compared to CO2 elimination. Now, in the next experiment, the water-restricted mice and the normal mice were given reasonable amounts of water, and then they were tested again. And then again, they got mild chronic water restriction on renal water conservation, and authors looked at what happened to these mice, and they have a difference in blood sugar responses. And the problem is not related to an inability of the water-restricted mice to concentrate their urine, because they can still do that great. And their blood pressures are a bit lower than the normal mice. And their inflammatory markers, here's IL-6, is much higher than the mice that are not water-restricted. And if we look at their organs, they have fewer glomeruli. I'm not quite sure how this comes about, but they do, and they have some evidence of fibrosis, and they get a certain degree of cardiac fibrosis, and that's shown here. So they have target organ damage just on the basis of being water restricted. And their sodium values are above 140, and they range between 140 over 150. Then the investigators looked at the EPIC studies. These are huge epidemiological studies in the United States where people are followed until they die. And they looked at the EPIC patients based on what their serum sodium levels were. And most of them have a serum sodium that's below 140, over 1,000. But then we have these patients that have 141, 143, 146. And in patients that run chronic hypernatremia, they get more claudication, they get more diabetes, they have more asthma, they get more strokes, and they have higher blood pressures, and they get coronary disease and renal disease and all these other bad things. And that's shown in this table. So what the authors propose, that their mouse model shows lifelong water restriction results in elevated inflammatory markers, elevated clotting markers, weight loss, impaired neuromotor coordination, and shortened lifespan. And in the ARIC studies, in these human epidemiological studies, elevated inflammatory markers, decreased during the last 15 years of life and weight, accelerated decline of kidney function, things that are quite reminiscent of what happened over here. And so here's the spread in the sodium levels in the ARIC studies. And about half the patients have sodiums of above 141, and they're then stuck with having these problems. So I thought that might interest you. So maybe I've been giving bad advice. Maybe the advice that the people should drink more than 2 liters of the most expensive mineral water that they can afford is a good idea. Because the mouse experiment and the humans seem to indicate that hypernatremia is not a good deal. Now, the last issue is in the Lancet. Concerns this young woman, comes in with chest pain and a pneumothorax. And she said, this isn't new. Every time I have my menstrual period, I get chest pain. And I've had a pneumothorax before during my menstrual period. So these clever doctors thought she had a catamenial pneumothorax. So they did mediastinoscopy, or they put an endoscope in her thoracic wall and found these things. And this is endometriosis. And endometriosis can occur anywhere. That it occurs inside the thorax is uncommon. But catamenial pneumothorax is a known phenomenon, and you can read all about it here. So they treated her for endometriosis, probably gave her birth control pills or something, and it got some better, I assume. And so that's catamenial pneumothorax. Thank you very much for your attention. Ich dachte, es war okay.
Ja, ich wollte dir eigentlich einen Saft mitbringen, hab den stehen lassen, beziehungsweise aber